mean, this has been a terrific day. We've heard a lot of great presentations. And another thing I find really special about this whole event is that it's a family affair in many ways. Patients and their families that have come and interacting with their medical families. And so the keynote is very much that too. It's a family affair. We've got the doctors REUL, Dr. George REUL and Dr. Ross REUL. Ross is my good friend and partner, and his dad, Dr. George REUL, is going to be the main event. I would say heart surgeons, we're kind of an odd lot. We love history. We admire expertise. And I would say that many of us have hero worship. And we're very fortunate that in Dr. REUL's, we have all of that. Not only was Dr. REUL a part of cardiac surgery history, he very much made cardiac surgery history. When I was up in Boston, we would think, having a series of 100 or 200 cases was a big deal. At the Texas Heart Institute, that was basically a day at work. Dr. REUL and Dr. Cooley, they really were the place of legends. Technical mastery. Dr. REUL did well over 14,000 cardiovascular operations. Imagine having the opportunity to touch the lives, literally and figuratively, of over 14,000 people. He's trained hundreds of cardiac surgeons from over the world. So his impact on the number of people that he's helped are, I would say, easily in the hundreds of thousands, if not millions. And he has shown us in heart surgery not only what could be done, but what should be done. So with that, I'm going to turn it over to his son, Ross, and I'm very excited to hear about Dr. REUL and his story. Ross?
Well, thank you so much for the incredible introduction, and thank you all for being here and your attention. And this is a great honor for me to share the stage with a legend and my hero for all my life, obviously, and someone who I'm very fortunate to have shared the operating room and to share the stage with. Well, welcome back to Baylor College of Medicine, where it started, and welcome to the Methodist Hospital, where all of this is going on. And I know it's been a long time. When you came here, this was where Baylor College of Medicine was, not anymore. But now this is the Methodist Hospital, and I'm very fortunate to be here now full time, and it's good to have you back in Methodist Hospital. It's been a long time. And I wanted to ask you, just starting out, you came from a non-medical background and a non-medical household, and I was wondering what your greatest influences were that got you on the path towards medicine.
Well, I guess I was always around a lot of sick people, and they always needed help. So I think I've always been interested in helping people, of course, being a young, ambitious person. I also was interested in engineering and structures and art, and all these things put together really pushed me right into surgery.
Well, you started out when you started out in medicine and you were in general surgery. I think Dudley Johnson was probably instrumental in your interest in vascular surgery early on. During your general surgery time there, you were actually drafted into the U.S. Army and sent to Vietnam. And when you got there, a lot of us in residency, a lot of people used to complain about difficult working conditions and work hours and things like that. And before you even got to your formal training in vascular surgery, you were sent over to Vietnam and actually made chief of vascular surgery in Saigon. And what was that like, and what did that have to do with the rest of your career?
Well, I wasn't exactly chief of vascular surgery, but I did see a lot of blood. And it wasn't in Saigon, it was in Long Binh. I was probably fortunate to endure that period of time, because regardless of whatever's happened in the operating room, at least the ground's not shaking underneath you, and the walls aren't coming in, no one's shooting at you. So at least not until the present time. I think that helped to prepare me for the rigors that were ahead in surgery.
Must have been an incredible experience, and something that kind of probably prepared you for Ben Taub Hospital in the days to come. But you, when you got back, you did some research and finished up all your training, and then came to Houston to join Dr. DeBakey and Dr. Cooley at here in Houston in the medical center. And what was it that brought you to Houston?
Well, what else? Y'all, like you say, I think everything was happening here. Started sort of with the Astrodome, and then the development of the medical center as extended out, and it was really the cowboy type of atmosphere that was here, and the can-do-all atmosphere that attracted me, and of course the volume of surgery, and my interest in cardiac surgery, of course, and congenital heart surgery in particular. As I was in my general surgery training, I found that there were very few surgeons who call themselves congenital heart surgeon that actually could operate and have good results. So I knew that I could obtain that here. Of course, that's why I came here with the two greatest images on either side of cardiac surgery.
And so any memories or experiences with working with under both Dr. Cooley and Dr. DeBakey? Anything you can share?
I can't recall a thing. As they say in depositions,
I refuse to.
I don't recall. Yeah, well, I think, everybody knows the difference between the two individuals. I think I started out working when I came here first in April of 1969. I was interviewing, and I was at the old Shamrock Hilton Hotel there, looking at TV before I would come down the next morning, and they announced that Dr. DeBakey just fired Dr. Cooley, and that because of the use of the artificial heart, and that there was great controversy ahead. So when I interviewed, I found that we would be the last surgical residents through the combined program, where we would train with both Dr. Cooley and Dr. DeBakey and all the associates. And after those 2 years of my residency, the program would close down. I was fortunate to spend 6 months with Dr. Cooley, and at that time, of course, I was able to observe from 3 to 8 operations in congenital heart surgery each day that I would assist. So we were exposed to quite a lot of congenital heart surgery. And besides that, the Department of Cardiology, Pediatric Cardiology at the Texas Children's Hospital had a very great program with Dr. Dan McNamara. And each one of the cardiologists there were individuals who had interest in each specific major category that you see today, and all were pioneers. And we had a conference every Saturday morning on all the patients that would be operated the next week, followed by a conference given by the staff to the fellows and residents on congenital heart surgery. So that was my introduction. And at the time when I finished my residency in 1973, I stayed on at Baylor College of Medicine and was assigned to Ben Taub Hospital, a charity hospital, as you all know, Harris County Hospital. And I became the chief of cardiac surgery there, vascular surgery, thoracic surgery, and one half of the general surgery program. I also was the chief of the pediatric general surgery program. And it was interesting because I went to Philadelphia Children's Hospital to observe a mustard operation with Dr. Ian Aberdeen. And I looked at their surgical log, and we were doing more congenital general surgery, our residents and I, than the whole Philadelphia Children's Hospital, which was at that time the #1 children's hospital as Texas Children's is today. We also were doing about half the cardiac surgery. At Ben Taub, we had 4 ICU beds, and we for the entire service, and a recovery room of some 19 beds. So we had to improvise. But one of the pediatric cardiologists, Dr. Bob Williams, had just come from Great Ormond Street where he spent a year learning all the newer techniques, and he was interested in starting a program at Ben Taub Hospital for pediatric cardiac surgery. At that time, and as is the present time, in all these generations, about over 50% of all births were on welfare patients, and they all came through either Jeff Davis or Ben Taub. So we saw firsthand the entire population of the city of congenital heart disease. We were able to pick a few cases here and there, and we ended up having started a program. And that's where I became more interested in congenital heart disease.
At that time, there was really not a lot that, the pioneers of cardiac surgery at that time, before you started, Dr. Cooley and Dr. Blaylock, Dr. Lillihei, and others had, they really were able to develop very, at that time, simple but elegant operations that they could get patients to survive in situations where there was no other hope. And so they put together these operations that with limited resources, with a heart-lung machine that was rapidly deleterious to your body. Dr. Cooley's operations were measured with a stopwatch, the timing of those operations. And then in your era, when you were doing this, the operations had become more complex, really more reparative, and what things were going on during that evolution of early congenital heart surgery when you were able to get patients to survive to the point where they could really benefit from an adult cardiac congenital heart surgery?
Well, I think if you would imagine the scenario of our situation in the early 70s and even through the mid-70s, there was no echo, there was no cardioplegia, there was no prostaglandin, there was no cine arteriograms, only plain single films, and the catheterizations were done with some difficulty. We used a stethoscope and the chest X-ray and the EKG, as you saw up here, to diagnose patients, and also digital techniques, which were not digital computer techniques, but digital techniques with the hand to examine the heart at the time of surgery. We would do our own heart cath in the operating room with needles and palpations and insert the fingers in various chambers and all kinds of things that you wouldn't imagine we would do today with these beautiful pictures you see up here. Well, those were the cons of that era. The pros of that area was that Medicare and the Human Health and Human Services was just being established by by President Lyndon Johnson, like a doctor, and it was in its infancy, so that there was no bureaucracy, there were no long forms, no computers. All of our data was kept on IBM punch cards by one person, and we could obtain any amount of data for publication at any time. The other great pro of that time was that the surgeon was the only interventionist. So we didn't have people helping us dilating things and putting various catheters everywhere. So I think even though things were bad from that point of view, we gradually developed the use of prostaglandin, which allowed us to sleep the night until the next day or maybe the weekend. In the early days, we had to do shunts on these babies just as they were born. So we developed various techniques to do these shunts under emergency situations with rather questionable anesthesia and no really ancillary drugs. I think one of the memorable things is doing the Waterston shunt on newborns at 2 o'clock in the morning when they had to be done as an emergency some 2 or 3 hours after birth. This was, the Waterston shunt was done at Great Ormond Street first, and by Dr. Waterston. Dr. Cooley picked up on the shunt early, so it became the Waterston-Cooley shunt. And as we did more and more cases, it became the Cooley-Waterston shunt, and eventually the Cooley shunt, which is not called now. And in fact, we call it the cool water shunt or the water cooler shunt. But as it became apparent that these babies were having trouble with pulmonary hypertension and kinked pulmonary arteries because of the torque of the aorta on the anastomosis, it became again the Waterston-Cooley shunt, the Waterston shunt, and eventually just the aortico-pulmonary shunt. So that was a progression of our experience, which was quite typical of all the procedures we did. And eventually it balanced out so that we could begin doing large volumes of these babies and infants and young adults. We didn't do much neonatal surgery, and on a recent trip to India, I noticed that I went to Chennai to the pediatric hospital there, and they were doing 1,000 operations a year on congenital heart disease, and all of these kids were the age groups that we used to operate on for open heart surgery. They waited to the age of 2 or 3 or 4. So you saw this large cadre of all these things that none of our residents or trainees now are seeing because they see only neonates. So they saw the so-called adult congenital heart groups of patients and were operating on them. So it sort of made me think that we should have a reverse training program and send our residents to India to train in these cases because they were so unusual here. And many other thoughts I have, of course, but I'm telling you much more than you want to know, I'm sure.
Well, you know, it's interesting when I started rounding at Texas Heart Institute, I remember walking through the surgical ICU and seeing, you'd walk in, see a crib next to an 80-year-old gentleman who just had an aorta bifem next to an ascending aortic dissection, and then another crib, and these were all in an open ward system. And nowadays, back then it was people would kind of wonder why do you have babies in an adult hospital, and these days we start talking about should we have adults in a children's hospital, and so this whole field of adult congenital heart surgery is really a testament to the survival that we've been able to improve over the years, and but it's also a very interesting situation now where we, the resident who finishes an adult cardiac surgery program is required to first assist on 10 congenital operations, and they're required to know kind of the basics of congenital heart surgery, anatomy and physiology. And so nowadays, I think it really requires an expert in adult congenital heart surgery who can take care of the complex problems that we see. What are your thoughts on the development of an adult congenital heart surgery program?
Well, I think that this meeting today typifies what it should be. It should be a separate specialty in its own, closely applied with the congenital pediatric cardiologist. Not only cardiologists, and surgeons, you need cardiac MRI people, diagnosticians, interventionalists, and all the subspecialties, just like you have in pediatric cardiology. And the pediatric problem with the adult population, I first observed when we started doing more adults at Texas Children's Hospital. The adults couldn't fit into the bed. That was one thing. All the instruments were too small, even endotracheal tubes. And they really didn't like going to the playrooms every day. And when you go on rounds, you'd see Mickey Mouse on the wall and some big man lying with his feet over the top. So what are you going to do? You're going to have an adult type of program. So originally, Texas Children's Hospital was a part of St. Luke's Hospital. It was run by St. Luke's Hospital. So it was all together, and as we separated, we had to have our own ICU designed at St. Luke's. Our operations were still done here until the new building came about, and then we had to go across the skywalk back and forth every day between each case that we were doing. So it became rather complicated, but now it's all centered in that one building, and that's the way it should be. And then, of course, here there's a real interest in this program, and as shown today, there are more patients with adult type of congenital heart disease than there are newborns. So I think it's a tribute either to poor diagnosis in the early stages of infancy or better results by the surgeon so they can last longer.
Well, these, you know, your training and your experience and everything that led you to this level is really been a great gift to the world. And I think you know, you've trained over 1,000 postgraduate trainees. There are countless residents, fellows, students, visiting physicians who call you their greatest mentor and who say that you're the greatest mentor they had. And who are your great mentors, and what did they do to influence you to become a great mentor, coming from your favorite mentee?
Well, in the first place, I think that we never really had a teaching program. We had a learning program. Everybody observed, and there wasn't much hands-on work till later on. But just in seeing a typical week of operations, which were about maybe 20 to 35, 40 operations a day, of all the most complex and varied type of disease processes, was enough for the education. And then we'd expect them to go out and do the work after some hands-on training. So it was quite different. But as far as my own mentors are concerned, I had my best mentor, of course, was Dr. Cooley, and Dr. Cooley, and Dr. Cooley. I spent, I was probably the one who was the longest employed assistant chief of surgery for 40 years. But he was my mentor. And of course, every other surgeon I met, or from the fellows up to the staff of various hospitals and international situations, you always learn from somebody something. And here, when I was in my residency, we had the ideal situation of both Dr. Cooley and Dr. DeBakey, but also Dr. Crawford, Stanley Crawford, who all of you may remember, Jimmy Howell and George Morris, the three associates of Dr. DeBakey we spent time with to learn their own techniques. So I think that type of exposure was really very good. It wasn't the one-on-one resident to staff type association that most programs had, but we did have the opportunity to have so much volume that we could teach.
Over your 40-year career, you were really universally respected and admired for your mastery of surgery and your mentorship. But you've performed over, probably close to over 15,000, maybe 20,000 major operations in your years, and you were considered an absolute master surgeon in vascular and cardiac, thoracic, even general surgery. But in congenital heart surgery, that's where even to this day people talk about your surgical artistry in legendary terms. And what were your fondest memories of operating on congenital heart patients? And I still meet your patients who you operated on 20, 30 years ago, and they come to me and sing your praises, and they may be here for another checkup for something else, and they introduce me to their families, and that's a very touching thing to see.
Well, I think at least they don't bring their lawyers with them. You can see this is typical of Texas and Houston in particular. I was started out with 14,000 operations a year, and I'm up to 20,000 already.
Well, the 14,000 were categorized.
That's what they used to call Baylor baseball. When I first started writing my papers at Baylor as a resident, I would go to an anonymous staff member and show him my data, and he'd say, well, that's interesting. Let's take that 5% and knock it down to 1%. Let's add 100 more patients. But when I went to Texas Heart, we had really true data finally. And this was obtained by one little girl who stayed with us for 20 years in a back room, looking at all the charts and putting all of them on punch cards with a long spear so we could pull up various series, and bang, you could write a paper within 2 hours because you had all that data available. And then we developed this computerized program with a whole staff of data harvesters and whatnot, and we couldn't even get the amount of carotid artery surgeries that we did in 1 year. So things really have to, we're on a small scale in a large situation are much better, I think. But what was your question?
The question is about what kind of fond memories do you have of the patients you cared for, and the.
Well, I think each patient you have an individual contract with, and the surgeon always was told, well, while the patient's in the hospital, you should have to take care of him. You have to see him every day, and you shouldn't charge for that, et cetera. But you should see him every day, or if they're sick, every to a month. But once you have your patient, you should be able to regulate their care somehow or another. And I think that's the thing I missed out on, because I never saw my patients once they were operated on, and a few days in the hospital. That was usually it, except for communication by cards and things. Dr. DeBakey taught me something when I was a resident. Every single one of his patients that he ever saw, whether they had disease or not, came in for diagnosis, he would have them come back every year to see him, and he would do arteriograms and whatnot, and had developed a huge following because of that. Our pediatric cardiologists were really very good at following patients, but nowadays with the way things are so mobile that patients move on, and they're really not followed well. At any event, I think that my greatest pleasure was to see these patients grow up and be productive citizens. And I've had several patients that had, for instance, tetralogy of Fallot, and went on to have a baby, and who had tetralogy of Fallot. I haven't gone to the third generation, but the two generations of the same disease, same family, and have taken care of them. And it's very satisfying. I might say with follow-up, we had one interesting thing that came to my mind when I was asked to do this, and that was a patient that Dr. Cooley and Dr. Hallman operated on in 1965. He had anomalous origin of the left coronary artery from the pulmonary artery, and they were the first to detach the artery and sew an interposition graft to the aorta to make a normal circulation. A little piece of Dacron graft was used, and the patient did very well. He was operated in 65 at the age of, I think, 10, and then, no, at the age of 5. And then he came back at the age of 10, had a cardiac catheterization and showed the artery to be patent and the heart normal, and he was asymptomatic. Well, he was sort of lost to follow-up, but when I was going through one of our usual sweeps that we made through South America to see our patients and to bring more patients, I was with Dr. Leachman, and when we saw this boy, this was probably when he was 19 years old or so. He was as tall as I was, and this was in Lima, Peru, and Peruvians aren't usually that well developed. He was very healthy. He was playing soccer, and he didn't want to have any more examinations or studies. He had a normal electrocardiogram, so the graft, I'm sure, was still open. Well, some 19 years after the first operation, he was playing soccer at the age of 24 and had sudden death. And I think that is an example of why we need to follow all you patients and patients that have had congenital heart disease. We know now that the graft, of course, doesn't grow, but everything around it does and pulls it off or shuts it off. So every type of operation that we've done has some type of thing that should be followed. And it's very important to follow a patient and not to say you're cured, you're done. And I think that was one of our mistakes in the early days.
It sounds like with the field of adult congenital heart surgery, the follow-up has been, they've been really trying pretty hard to get good follow-up. It's very hard to follow patients when they're feeling good now, and you have a young patient who suddenly feels great, and it's hard to get them to come back sometimes, but I think the efforts by the cardiologists especially and the cardiac surgeons also to get the word out and make sure that they're following patients very closely is critical to the outcomes. So I'd like to just say that you've saved countless lives and had the experience of teaching countless residents to do the same thing. I had the pleasure of learning under your guidance, and I carry your message to the next generation of residents and fellows every day. And I just want to tell you what a pleasure it's been to hear your perspective and share the stage with you, and turn it back over to Tom.
I'd say I'd like to speak for all of us in the audience. This has really been a treat to listen to you both talk and learn about the great days of heart surgery and congenital heart surgery, and we'd really like to thank you both very, very much.